Hello and welcome to the Laboratory Matters, where we discuss all that matters in the laboratory. We all know that normal red blood cells or erythrocytes are discoid in shape. They're discs. As students of laboratory hematology, we also know that not all red cells are discs. This series, which stretches over 4 modules, I will be discussing about those red cells which assume various shapes. We shall see why they have those shapes, how we recognize them, and what is the clinical significance about that particular shaped red cell. So let's get cracking. This is a normal red cell which looks like a disc. It's semi-concave or rather biconcave in shape, and we know the dimensions. This is the normal red cell. On a stained smear, you see that as a spherical cell with central pallor, which is 1/3, and hemoglobinized over 2/3 of its diameter. But what are those red cells which are not discs? They are called poikilocytes. And how do we define a poikilocyte? It refers to a red cell with an abnormal shape, as seen on either a well-stained Romanowsky stain smear or on scanning electron microscopy. Now, if you look at my smear or your smear, that is apparently normal, healthy people, you are going to find a small portion of the red cells which have abnormal shapes. So does that make it a poikilocyte? It is a poikilocyte, but is it clinically significant? It is significant only if greater than 10% of the red cells have these similar abnormal shapes. So only then should you report it and should you think that it is associated with some clinical abnormality. Now, why do we get a poikilocyte at all? So there are a number of reasons. Most important among it is abnormal erythropoiesis, which could be either effective erythropoiesis or ineffective erythropoiesis. Damage to the red cells after the formation as they leave the bone marrow. This is another very important cause of the formation of a poikilocyte. Now, this damage could either be intrinsic or congenital because of a hemoglobinopathy, because of a membrane disorder of the red blood cell, because of enzyme deficiencies in red cells which lead to some disorderly metabolism of the red cell. Or it could be because of extrinsic factors like drugs, chemicals, toxins, heat, abnormal mechanical forces, so on and so forth. So, when you look at poikilocytes, you have to first recognize that there is a poikilocyte. You have to recognize that it forms a significant amount of poikilocytes are there. It constitutes a significant proportion of the red cells that are there. And then we find out what is the etiology or the etiopathogenesis of these cells. Now, how have the poikilocytes been classified? Okay, it is obviously based upon the shape of the cell. So you have spiculated cells, which means these red cell membranes are spiculated. Then they can be elliptocytes and ovalocytes, teardrop cells or dacryocytes, target cells or podocytes, spherocytes, irregularly contracted cells, stomatocytes, sickle cells. This may not be the entire classification, but they constitute the most significant kinds of poikilocytes that one may see. So over the next 15 to 20 minutes, I shall touch upon spiculated cells. We shall cover the rest of them over the course of the next 4 modules. So spiculated cells are again divided into echinocytes, acanthocytes, keratocytes, and schistocytes. And of these, schistocytes are very, very important. So we shall start with them. Okay. Now, schistocyte is also called a fragmented red cell. Now, the ICSH, or the International Council for Standardization of Hematology, has defined the schistocyte. So you can't call any random fragmented cell as a schistocyte. It has to be smaller than the intact red cell. It can have the shape of a fragment with sharp angles, straight borders, small crescents, or helmet shape or keratocyte. So even the shape has been defined. It can't be a random shape. These schistocytes lack central pallor and can have irregular triangular shapes and pointed projections. So the projections in these cells, because of which they are called spiculated cells, can be pointed. The schistocyte cytoplasm is usually homogeneously stained, but occasionally the central area can be pale, somewhat paler than the periphery. So though by and large the schistocyte will be homogeneously stained, you can also have schistocytes which are pale in the center and staining darker towards the periphery. Now, if you find these other fragments, like the triangle cells, the keratocytes, the helmet cells, small crescent-shaped cells, then you also look for microspherocytes. And what are microspherocytes? They are small, deeply stained RBCs. Sometimes they may have protrusions, but without sharp angles, without straight borders. And then if you find such cells, which just look spherical, small and spherical, without any spicules anywhere, you will include them in your schistocyte count, but and only if the rest of the various other cells that we described till now are present. This is not my definition. This is the ICSH guideline or the ICSH definition for a schistocyte. So we look a little more deeply into triangle cells. Now, we have seen all of this, okay? It's not something new. I'm not reinventing the wheel. So, triangle cells, these are all triangle cells, okay? They're small fragments of varying shapes, sometimes with sharp angles and spines. And this is really one of the most common kind of fragmented cells that we will see. Sometimes they can have straight borders or they can have little rounded edges on one side. So they will look like microcrescents. They're usually darkly stained. See this cell? It's nicely darkly stained. And very occasionally, like I said earlier, can have a pale staining cytoplasm because of the loss of hemoglobin at the time of fragmentation. So all these cells which have like three sides maybe with some spicules sticking out with homogeneously stained cytoplasm are called as triangle cells. Next is the helmet cell. These are damaged erythrocytes with one single, rarely a double amputated zone highlighted by a straight border with sharp angulated edges. The missing cell portion corresponds to the fragments that have been split off as a result of a break of a fibrin strand. So you will have these kind of cells which are like helmets, and you will have the cells which have been broken off from them, which could be the rest of the fragmented cells. Then you have keratocytes or cells with horns. So keratocytes are cells with horns. They can have large fragments, small fragments, and you can have spicules which are separated. So they can have spicules which are separated either by a straight line or they can have more spicules over there. They look like helmets, inverted helmets if you can imagine, with two pointed like what the demons have. They occur in the same conditions as triangles, crescents and helmet cells and have been formed by rupture of one or more peripheral pseudovacuoles and subsequent fusion of the cell membrane. So something from here is just gone away. Something from here has just gone away. That is the remaining part of the red cell, which is a fragment. Then you have a microspherocyte. Like I said, if you find the rest of them, then the microspherocytes start becoming significant. So these are small sized hyperdense red cell with a round shape, increased staining, no central pallor. It should be included with the schistocyte count only in the presence of the other shapes. It's formed when the rupture reduces the membrane surface in relation to the cytoplasmic volume. So there is a discrepancy between the surface and the volume, and so the cell shrinks and becomes a small and hyperdense cell. It can also result as a result of a shape change of other schistocytes which take place as you move towards the feather edge. Now, this is something that I want you all to remember, that when you're looking for fragmented red cells, you should look in the ideal zone and beyond, not towards the tail end. Because what happens in the tail is that even these fragmented cells will start looking like spherocytes or small microspherocytes, and you may actually miss the diagnosis or miss the presence of fragmented red cells. Now you've identified the schistocytes, but it doesn't stop there. It's important to tell your clinician that yes, this particular sample has schistocytes. So how do we do that? How do we tell the clinician? We need to have some kind of a common method of reporting, and therefore comes the enumeration of schistocytes. There have been so much of emphasis placed on the enumeration. You can either do a manual enumeration or it can be an automated enumeration. So you have a smear which is well stained. Now the smear can be either made manually or it can be automated slide maker, stainer, whatever, depending upon your particular laboratory. Now count should be done in the ideal zone as many fragments become spherical at the tail. This is what I referred to earlier. Now, microscopic evaluation should be carried out at medium magnification with 40, 50, 60x power objective with oil immersion if necessary in combination with a 10x or a 12.5x eyepiece. So, which means you either do it at high power or you do it at oil, whichever is convenient to you. You count at least 1000 RBCs, find out how many fragmented red cells are there as you're counting 1000 red cells and express it as a percentage. Now, when do you report it? We go back to what we said earlier, only if it is greater than 10% of the total number. So, if it is the main morphological abnormality on your smear, then you will report the count of the schistocyte. Now, in well-smeared peripheral blood specimens from normal individuals, it is assumed that each high-power field displays 200 red cells. So, the criteria of at least 2 schistocytes per high-power field, and I'm talking here about 40x and not about 100x. So, you should have at least 2 schistocytes per high-power field, which will come to roughly about 1% schistocytes. Now again, the ICSH group recommends providing only a qualitative report for those samples where schistocytes are observed in a context of multiple other poikilocytes which are present. So if you also find echinocytes, if you also find target cells, if you're going to find spherocytes, then you will say schistocytes are also seen. But if you're only finding schistocytes with occasional spherocytes, then you will give a quantitative report. A percentage of schistocytes above 1% is a robust cytomorphological indicator for the diagnosis of thromboembolism in adults. So it's very important that we keep this 1% in our. So you can do it manually. We've been doing it manually. Probably many of us have been reporting it as present, absent, numerous present. But now it's important, according to the guidelines, to give a numerical value, to give a quantitative estimation of the schistocytes. Now, schistocyte count automated. It's a useful complement to microscopy as it provides rapid results with a high negative predictive value. So if there are no schistocytes, it's significant. Now, automated hematology analyzers, especially the more recent 5-part ones, they have flags for fragmented red cells. Now, the question that is in your mind is how reliable are these flags? Because sometimes you get these flags even if there are macroplatelets, even if there are microspherocytes. So yes, it is not extremely reliable and one needs to evaluate these things in your own laboratory setting. Some provide an automated FRC count on the EDTA anticoagulated blood samples through the measurement of forward scatter and the intensity of fluorescence or by two-dimensional optical analysis. So depending upon whether you're using this manufacturer or that, the technology will vary, but you can get a FRC count, and that count is fairly reliable and it has been validated in several studies. So then if you have a counter which will give you this at no extra cost, it should be at no extra cost for every sample that you process on the cell counter, then it's a fantastic thing. You don't have to worry that you're missing something. So it's low cost, it's rapidly available because when your CBC report comes out, your FRC values are also there. You can develop a cutoff in your own labs and make a smear and then check it out. So its reproducibility is excellent, and especially when it's at high counts. Maybe at low counts, it's still not very well validated, but at high counts, definitely it's a it's a good piece of technology to have. If you're following up a patient who's got DIC or who's got HUS, and you want to look at the serial evaluation of these schistocytes, then this is a very good alternate. The stability over time is limited to less than 24 hours. That means you can process a sample only within 24 hours of collection. False positive FRC is obviously due to the presence of platelets or macroplatelets. False negative FRC is due to samples with a high MCV greater than 105 femtoliter, where fragments are counted as microcytic red cells. So yes, it's not that you have automation, everything is hunky-dory. You have to keep on looking at the samples that you're feeding, cross-checking it with a peripheral blood smear or a digital morphology analyzer, whichever you have in your lab, and you will arrive at something that suits you fine and you will validate it in your own laboratory setting. Now, what are the guidelines or recommendations for automated schistocyte counting? FRC results and flags provided by the automated systems are helpful screening tests for assessing schistocytes. Definitely. The absence of FRC is a valuable parameter to exclude schistocytes on the blood film, except when the MCV is elevated to greater than 105 femtoliter. At that time, you please make a smear and you look at it. Now, multi-center studies are required on automated analyzers to generate an FRC reference range and verify inter-manufacturer and inter-method comparability. This is an ongoing process. These are the latest guidelines anyway. Samples with positive automated FRC count should be reviewed by optical microscopy to confirm and count schistocytes. Schistocyte pre-classification provided by digital morphology also requires confirmation with optical microscopy. This is what they're saying till now. Obviously, with the advent of AI, with more and more digital morphology coming into play, probably this will also change in their next set of recommendations. What is the reference range? Till now, what has been provided for us by the guidelines, in a normal adult, less than 0.2% of red cells can be schistocytes. So anything that is above this should be looked at. In the neonates, about 1.9% of red cells can be schistocytes. And if it's a premature neonate, 5.5% of red cells can be schistocytes. So this is what is the, uh, the reference range that has been given for the schistocytes. So schistocytes are important. We need to identify them. We need to enumerate them. We need to give a quantitative report, especially if it is the main poikilocyte in our peripheral smear. Now, what are the conditions associated with schistocytes? Certain genetic conditions like thalassemias, CDA, hereditary pyropoikilocytosis, acquired disorders when erythropoiesis is megaloblastic or dyserythropoietic, consequent to mechanical stress in microangiopathic hemolytic anemias, prosthetic valves, and direct thermal injuries. So these are the clinical conditions where one would see schistocytes on the peripheral smear. Now, if there is a clinical suspicion of TMA, and there is a positive automated FRC count, you make a smear, look for the presence of schistocytes. Either you look at it manually, or if you have a digital scan, you look at that. Are these schistocytes the most prominent poikilocyte seen on your smear? If it's yes, you count 1000 RBCs, and if in adults or neonates is less than 1 and in prematures it is less than 5%, then it's unlikely to be a thrombotic microangiopathy. If it's greater than 1% or in your premature babies it's greater than 5%, then we are looking at a very high possibility of thrombomicroangiopathy. If the schistocytes are not predominant on your smear, but there is a strong clinical suspicion for TMA, you do a serial evaluation of your peripheral blood smear. Or you also look for evidence of other diagnosis. So this is a 2021 guideline which was given for using schistocytes to predict or to assist in the diagnosis of TMA. This is pretty useful, and the enumeration is also very helpful. Now we move on to the other speculated cell, which is an echinocyte or a crenated red cell. Now erythrocytes that have lost their disc shape and they are covered with 10 to 30 short blunt spicules. They are of almost equidistant, same height, covering the entire surface of the red cell. They are regular. This is called an echinocyte or a crenated red cell. Now this is formed due to ATP depletion and increase in the lysolecithin. These changes in these membrane of the red cell is usually reversible. So you find plenty of these kind of, here. The most common cause of these echinocytes in our day-to-day laboratory practice is storage artifact, where there is a delay in making a blood smear. Stored blood post-transfusion. If you see, you will find spheroechinocytes, especially again towards the tail. Hepatic and renal disease, nutritional or phosphate deficiency, premature infants after transfusion. So more often than not, this is seen as a storage artifact. That's why it's important to make your smears within 1 to 2 hours of sample being collected. Then we move on to acanthocytes. Acanthocytes are almost spherical with 2 to 20 spicules, but they are of unequal length. They're distributed also unevenly, and some of these spicules have clubbed shape rather than a pointed end. And this results from a preferential expansion of the outer leaflet of the lipid bilayer that comprises the red cell membrane. So as we all know, the red cell membrane is made up of a lipid bilayer, and only the outer layer will expand, the inner layer remains as such. So because of this, you have some disproportionate or ununiformly shaped spicules, varying lengths, and some of them have a club-shaped tip. They cannot form rouleau, that means they don't aggregate. And this is not reversible as compared to acanthocytes. So if you look, these are the acanthocytes. They look distinct from the crenated cells of the echinocytes. So they are not uniform, they are irregular. This, if you see, this is an echinocyte and this is an acanthocyte. So you can easily see the difference. And where is this seen? Abnormal phospholipid metabolism, inherited red cell abnormalities like nephliod phenotype, postsplenectomy or hyposplenism, severe liver disease or spur cell anemia. So in severe liver disease, you'll find both acanthocytes and echinocytes. So they are easy to pick up on the blood smear. But unless, again, this is greater than 10% of the total red cells, it does not become clinically significant. Next, we move on to keratocytes. Okay, they have pairs of spicules, 1 to 2 pairs, result from removal of a heme's body by pitting action of spleen and by mechanical damage. So we've covered the spiculated cells. So what I want you to understand is poikilocyte is a red cell with an abnormal shape as seen on either a Romanowsky stain smear or on scanning electron microscope. And greater than 10% of the total number of red cells should be abnormally shaped for it to have clinical significance. The different spiculated cells are echinocytes, acanthocytes, keratocytes, and schistocytes. An echinocyte or a crenated cell is usually a storage artifact and or renal or liver disease. Acanthocytes are seen in abnormal phospholipid metabolism, severe liver disease, or renal disease. Schistocytes are smaller than intact red cells. They may be triangle cells, helmet cells, keratocytes, and they usually lack central pallor. Schistocytes are expressed as a percentage after counting at least 1,000 red cells in the optimal area on a manually, that is on a well-stained peripheral blood film. Schistocyte count is feasible only if it is the main morphological abnormality of the spear. Automated cell counters can give you flags for the presence of fragmented red cells, can give you automated counts, and this is a very rapid method and pretty reliable method of the assessment of the presence or absence of a fragmented red cell. And if that count is clinically significant, if it is greater than 1% in an adult, then one needs to look at the smear and try to assess the etiopathogenesis of the schistocytes. Very useful for monitoring of a patient with any kind of an illness which causes schistocytes. So with that, we finish module 1 where we looked at spiculated cells. I want you to continue watching, subscribe to my YouTube channel, and also visit us at thelaboratorymatters.com for more such information, for more interesting topics on laboratory medicine covered in very easy to understand and easy to digest modules split into small different sections as part of a series. So until we meet again, in our series titled All Red Cells Are Not Discs, Module 2, here's happy watching from the Laboratory Matters. Thank you.